we're going to set a rise time that you're going to keep for every day of the week. Okay. So we're going to decide when you're going to get up every day of the week. And then we're going to count backwards from that 6 hours. That's your new bedtime. Prior to that bedtime, you're going to give yourself 30 minutes of proactive wind down time.
Well, can I start by thanking you, Dr. McCarty, for joining me on the podcast today?
I'm happy to be here.
Your website is empoweredsleepapnea.com and your book, Empowered Sleep Apnea, a handbook for patients and the people who care about them. And your podcast also carries the same name. And I would urge listeners to head to your website because it's not really what you'd expect. Dave, you have an artistic flair, which is certainly evident on the website and throughout the book. Can we go back to your mantra, one of patient-centered care? And I would have thought a way of humanizing the relationship between you as the doctor and your patients.
Absolutely. Yeah. Patient-centered care to me means not necessarily just leading the patient to the right place. Many physicians sort of approach the practice of medicine as, do you have this problem? And if so, we'll manage the problem in accordance with best practices, and that sounds right. But the problem is people come to us with a set of complaints. They don't come in saying, just manage my sleep apnea. They come to the doctor saying, I'm not sleeping that well and I feel crummy. And my partner says that I make noises at night. So we have to start with a real kind of complex goo and figure out a way to put structure on it for people. And the essence of the practice of medicine is all about management of that complexity. And the only way that I know of to do that is with a patient-centered modality, where instead of showing the patient the pathway from point A to point B, instead, what we're trying to do is shine a light. It's as if we're in a dark cave and, I have a little more training and experience. I can shine the brightest light I can to show you every nook and cranny of this cave that I can. And we'll explore it together and figure out how best to manage, and how best to navigate.
Okay, so sleep apnea, just to put it into context for people who aren't familiar with the term, I know it's a complex condition, but can we talk about it generally speaking?
Yeah. Well, I'm glad you asked that question, because I think if you went to 10 different providers who have seen what sleep apnea is from their perspective, they may give you a slightly different answer. But I'll give you a very generic answer, and then we'll talk about why it's complex, okay? So in a generic sense, sleep apnea refers to a spectrum of problems of dysfunctional breathing while asleep, okay? And those breathing patterns can take two forms, and they often overlap. One is called obstructive sleep apnea, and the other is called central sleep apnea. They're different. Obstructive sleep apnea means that when you're sucking in air, the airway gets kind of sputtered shut and it causes a blockage, okay? And that interrupts airflow and can be stressful and causes adrenaline levels to go up, and oxygen levels can sometimes drop with that too, okay? So that's obstructive sleep apnea. When that happens over and over again throughout the night, you don't sleep very well. Central sleep apnea is a different type of a problem of breathing during sleep. That's when, instead of breathing in a nice, slow, steady rate, one might have an arousal and have several gasping type of breaths. And then immediately upon entering sleep, there is a paused effort to breathe. So this unstable pattern of starting and stopping breathing is called central sleep apnea. And that exists on a spectrum as well. So when you break down, well, why does someone get obstructive sleep apnea? And why does someone get central sleep apnea? Then we start to pick that apart, and you realize that there's lots of moving parts within each of those labels themselves, right? So for obstructive sleep apnea, for example, one possible contributor is the open mouth breathing position. Isn't that odd? Just the posture of breathing with your mouth open puts the tongue a little further back in the throat, right? And it releases the tongue from the vacuum seal of the palate of the mouth. Now not only is the jaw rotated backwards, but the tongue is allowed to fall back. So for some people who get the diagnosis of sleep apnea, one of the biggest things they can learn to do is breathe with their mouth shut. It's amazing. But that's not going to be on the little trifold handout that you get that says, sleep apnea is caused by a floppy airway and we need to put you on a CPAP machine. So it's very different when you look at it from the patient-centered perspective and you're breaking it apart into sort of the different moving parts of these different disorders than it is if you're looking at it from the label perspective and, I've got a treatment for that and you have this label and here you go, right? It's a completely different thought process.
And how prevalent is the condition of sleep apnea now? I mean, are we seeing more sleep apnea today than we did, for example, 10 years ago?
Yeah, well, we're definitely seeing more of it because more people are looking for it. And by some estimations, the prevalence, if you want to call it that, it's estimated to be affecting over 1 billion persons worldwide. Like this is a big, 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 big problem. And only maybe 1 in 5 has been sniffed out and diagnosed. Now, what's coming and what is already here in some parts of the United States anyway, is the advent of automated testing systems that are basically wearable technology. And so there are several systems that are now in use. I've seen reports coming through on them. And what this allows is a greater reach for diagnosis of this disorder, which is sort of awesome. Yay, we can reach more people. But on the other hand, it also means that a lot of people are going to get this label kind of affixed to them because this little machine was worn on one night and they had a score that was high enough to land them in the diagnosis. And I don't think that we're yet ready to discuss the complexity of what that's going to do to us. Because the complexity of sleep apnea is such that, the many moving parts of obstructive sleep apnea versus the many moving parts of central sleep apnea and what's best for this individual person. Should we treat this problem? And if so, why? That discussion is a complex one. And that's the whole mission of the Empowered Sleep Apnea Project, is to put words to this massive complexity and give people the agency to actually navigate through this in a sensible way, give them back their sense of empowerment. That's what it's all about.
Given the complexity of sleep apnea, is it possible to flesh out some of the chronic conditions that are associated with people who have sleep apnea?
So this is, again, a very complex discussion because, we can get into what I call in the Empowered Sleep Apnea Projects, the 5 reasons to treat. Okay, so this is such an important concept in breaking down this complexity. For the project, I built a little island. I'm a cartoonist, as you said, and I felt like getting labeled with this diagnosis is sort of like washing up on a crazy island where the culture is different, the language is different, and so what we're going to learn to do is learn to navigate together. So I actually literally drew a treasure map almost. It looks like the stuff that I used to look at for hours when I was a kid was the maps on the inside cover of the Peter Pan illustrated edition that I had. I just thought it was so cool. And I thought, if we're going to engage a sense of adventure and a sense of willingness to explore, why can't we have a map too? And then all of a sudden it just became obvious. So on the map, the first place you enter is a place called the Bay of Narrative, because we have to figure out what your story is. And that's going to lead us eventually to something that I call the 5 reasons to treat monument and coffee hut. Okay, so the monument is basically all about 5 reasons to treat, which are risk, meaning risk to your life. Sleep apnea does end people's lives early, right? And it's not the same for everybody, though. That's the problem. So a discussion about risk really means breaking apart what we know and what we don't know about the different flavors of sleep apnea. We have to understand the jargon so we can understand the scores. Second reasons to treat is snoring. Some people snore with sleep apnea, some people don't, okay? Just because you don't snore, though, doesn't mean you don't have it, because silent sleep apnea is a thing. And many people are just snoring agnostics. They may snore all night long, and they just don't know it, okay, because they're asleep. But depending on how much you snore, that may be a valid reason all by itself, because snoring is an environmental terror to the people in the room with you. Snoring is vibrational trauma. There is evidence that links the risk of atherosclerotic buildup in the carotid arteries to the snoring intensity and duration at night. That's just from the trauma, the jackhammering that happens in the neck, So snoring is a reason to treat. Third reason to treat is the sleep experience, right? If you're sleeping poorly, sleep apnea is not helping that, okay? So if you're waking up a lot, if you're not doing well. Fourth reasons to treat is the wake experience. So some people with sleep apnea are sleepy. Some people don't feel sleepy, but they feel off. They feel scatterbrained. They have trouble multitasking, attention deficit, depression. All of these neurocognitive limitations can be part of the problem, and it can be part of the sleep apnea experience. Fifth reason to treat is comorbidities. Now that's a mouthful, but comorbid conditions are the also-ran vulnerable diagnoses. These are things that if sleep apnea, which is physiologically stressful, if sleep apnea is treated, these other problems might get better. Okay. And so the list of comorbid conditions that are vulnerable to sleep apnea is longer than my arms. Okay. And I'm 6'5". It is really long. And basically anybody who's like wondering whether this condition can be related to sleep apnea somehow, there's probably a way you can find that pathway, but high blood pressure, migraine headaches, grinding of the teeth, getting up multiple times a night to urinate, congestive heart failure, inflammatory bowel disease. All of these syndromes can be linked to the nonspecific stress of the up and down of the oxygen or the sleep dysfunction and sleep fragmentation. So what I would tell my patients is, take a look at your med list, take a look at your problem list, think about the things you see doctors and therapists for, and let's talk about those problems, because there's a good chance that many things on that list, the sleep apnea is making that worse. And if we get the sleep apnea under control, well, maybe those problems can get better. Here's an interesting connection that a lot of people don't know. So many people suffer from heartburn, reflux, right? It's often worse at night. So that, you go to the doctor and you say, well, I have reflux. And they say, oh, we have a pill for that. Let's give you some antacids, so you start taking this antacid at night. Well, lo and behold, that when one is trying to breathe, trying to suck air through an upper airway that is sucked shut, right? When you're doing that, you are exerting effort with your thorax and you end up pulling stuff out of your stomach up into your thoracic cage, right? So sleep apnea promotes the reflux, right? So when we connect those dots and we realize, holy smokes, if we treat the sleep apnea, then maybe we can get you off of this antacid that, by the way, because you've been suppressing stomach acid for the last 5 years, now you're iron deficient, because iron absorption is acid dependent, right? It's like dominoes. So, we got to get ourselves out of this mindset of just assigning these diagnostic labels and then moving on. We have to think about the person's narrative, right? Brings us all back to patient-centered care and what one of my new friends on this journey calls co-discovery. Co-discovery is the process by which provider and patient manage things in tandem, not one leading the other by the nose.
Well, talking of labels and ascribing labels to people, and incorrectly so, can we introduce the term Pikwikian syndrome at this point? And can you tell us about the really interesting origins of this term and how it was so inaccurate as far as people's perception of sufferers of sleep apnea were concerned?
Yeah, I would say that this is an example of what I call in my writing kind of the whole leviathan of sleep apnea is so complex that many providers have only seen one aspect of it. So if the sea monster is the size of the Titanic, then we're a tiny little microbe floating by trying to describe it. But I'm getting away from your question. Remind me again where I'm going.
The origin of Pikwikian syndrome.
The Pickwick Papers was the posthumous papers of the Pickwick Club, was Charles Dickens' first novel. It was published in serial form back in the 18-somethings. And Sir William Osler, who is kind of my doctor hero, he was the first chair of medicine at our America's first residency program, Johns Hopkins. So he described a syndrome that he was noticing in young people, that young, very heavy people who snored were often sleepy. Okay, so there's this sort of this understanding that if you have this triad of snoring at night, you're heavy, you also happen to be sleepy, there began to be a signal in the medical literature that people who had that triad were dying younger of things like heart failure. Okay, and because of that, it became kind of something that people started to need a name for. And Dr. Osler said, well, these are a lot like a character in the posthumous papers of the Pickwick Club, a funny little character that made his entrance literally to the book by falling asleep while knocking at the door. It's a character that they just call Fat Joe. So he was, and they had an illustration of this very rotund young man falling asleep and sitting at a table, So Dr. Osler said, well, this is not unlike the Fat Joe in the Pickwick paper. So they started to call it Pikwikian syndrome. And there was a lot of debate as to why people with Pikwikian syndrome were sleepy, because everyone agreed that, yes, this existed. Now you start to look for it and you have a name for it. You start to see that heavy people are often dozing off. So there's a big debate about why this is. And many people were of a mind that, well, all of that weight creates a restrictive pulmonary deficit. You can't engage your lung bellows as well. So you can't ventilate as well, right? In other words, you can't get rid of your CO2 as well. And there was one paper that was published, a case report of a heavy, snoring, sleepy person who was admitted to the hospital with hypercarbic respiratory failure. Basically, his CO2 level was really, really high. So there got to be this legend that people with Pikwikian syndrome are sleepy because they have CO2 narcosis, because, too much CO2 in your bloodstream can make you sleepy. So that was the assumption until the late 60s, when a French epileptologist named Henri Gastaut decided that he would use a brand new technique called polysomnography. Okay, this is a polysomnogram is a sleep study, but the epileptologist knew how to interpret brain waves, and this guy was really, really magnificent and seeing patterns within patterns. So he was one of the pioneers of the science of the study of epilepsy. And anyway, he decides he's going to use this brand new tool to study someone with Pikwikian syndrome, who actually is heavy, snores, and is sleepy. And what he found during this paper, during this experiment, this one-night study, is that this person was stopping breathing over and over and over again at night. And that was where sleep apnea was born. It was 1967, okay, 1966, I believe. And since then, we've thought about sleep apnea through the Pikwikian lens. The medical science has advanced with that lens firmly in front of our face. But it just so happens that in creating the scale that we use to rate sleep apnea, which is, how many of these obstructive events are you having per hour and what kind of obstructive events are they? There's a metric that's called the Apnea Hypopnea Index, or the AHI. And using this metric, we can now identify people who meet the standard for, so many events per hour, but they're not heavy, and they don't snore, and they're not sleepy, okay? We're getting fit young people now meeting these diagnoses. If you look hard enough, you can find it. And they've got narrower faces than, what we typically think of as, your Pikwikian syndrome heavy person. So we're seeing a completely different flavor of this. And it is a flavor of sleep apnea that often won't go see sleep physicians, because they don't want a CPAP mask. So what we start to see is a divergence of culture and language, because there is a whole new emerging field in dentistry called airway-centered dentistry, where these pioneers are trying to reverse engineer the way our faces are shaped, using functional things like, how are you swallowing and where is your tongue and things like that. Because all of these things, we now are getting the signal that that's part of the way the shape of the face is sculpted, is how a person swallows and breathes and chews. So knowing that, now we start to think about the paradigm of, sleep apnea is a floppy airways problem. Let's put a CPAP machine on that. We start to think about this in a completely different developmental part of our brain. And this is all going on. And right now, that I call them silos of thought. These different silos of thought have a hard time communicating with each other. So one of the real important messages of the Empowered Sleep Apnea Project is many moving parts, guys. We don't have the corner on the market on all the knowledge, and we need to find a language that we can talk about this complexity as a group with our patients, so that we can lay it all out on the playing field and we know what we're dealing with. So in essence, the Blue Book, which I call the beautiful Blue Book, because if you hold it, it is truly kind of a beautiful thing. That's really what I picture this is. It's that message of what this complexity looks like when we all have the language to talk about it.
Now, you mentioned the CPAP machine there. Could you just briefly give us a quick rundown of what a CPAP machine is, what it does, and how it benefits people with sleep apnea?
Of course, yeah, I'm using some jargon, and I apologize for throwing that out without explanation.
No
A
worries.
CPAP machine stands for continuous positive airway pressure. Okay, it is really nothing more than a glorified air blower that blows air into the airway. And most people can use CPAP with a nasal interface, which I would highly recommend if you're going to do that, because I'm not a big fan of the open mouth breathing posture. And the big oronasal masks can sometimes push the jaw backwards and makes it a little harder to get the pressure in there. So you need a higher pressure with those masks too sometimes. But what this does is, while you are generating that force to breathe in, you are sucking air through a collapsing tube. And most people can picture, if you're trying to drink a milkshake and you've got kind of a floppy paper straw, the harder you suck, the more that straw is going to collapse. Okay, so that's what happens essentially in the place behind the tongue and the soft palate. When a person is sucking to breathe, that gets sucked shut, and that's where the snoring sound is going to be generated from in many cases. And that person struggles until their oxygen gets low enough to set off the alarm bells that says, have a little arousal from sleep, take a couple of breaths, and then get back into it again. So the CPAP machine is going to be pushing gentle pressure to help keep that collapse from happening. Good thing. It's very effective for most people. It's probably not for everybody, but many people feel like it's the only option. And so one of the things that I would always do with my patients is talk about it in just very realistic terms. CPAP machine, I want this to be gentle to you. I want this to deliver just enough pressure to make you comfortable, but I don't want the thing, blowing you like a jet engine. I've had people come to me say, I tried that once and there's just no way. And when you dig deeper, you find out that what was done is a perfectly well-meaning technician on the durable medical equipment side provided them a device set on automatic mode. And the automatic mode allows the machine to kind of choose where it goes. And if you set a very wide range, these machines will often kind of, they can overshoot the target sometimes, and they can cause what I call in the book pressure toxicity symptoms. It's just too high, it's too uncomfortable. So I treat these CPAP machines like I'm sending somebody home with a dog. You don't want the dog to do whatever it's wants to do. It'll just abuse you. So I like to train it. I like to set a very specific range, and I like to follow up with it and make sure that it's not mistreating you. So again, you get me talking about CPAP, you're gonna keep me going if you let me.
Well, at this point, can we revisit the anatomy of the oral cavity? And is it true that the shape of our skulls have changed over the last 100 years, in part as a result of the fact that people are now being breastfed less and being bottle fed more?
Yeah. So this signal is definitely out there, and it's one of the main factors that's leading to some divisions within the silos of dentistry. Because on the standard orthodonture side, there has ever since sleep apnea has been described, basically, which is since the late 60s, there's been this a very defensive sort of tone towards, well, what we're doing is not causing sleep apnea. And so there's a lot of publications about how the airway size, because a lot of orthodonture is about pulling the teeth back into correct alignment so that the smile is very pretty. But what's happening is, with the retractive sort of forces, it is literally shrinking the size of the mouth. Now, once you get into the narrative of, wow, there is a line of scientific evidence that suggests that all of this malocclusion that we're seeing is not genetic. This is not, we weren't programmed to have crowded mouths. We weren't programmed to require our wisdom teeth to be removed, right? What we've discovered in the fossil record is that pre-industrial skulls, so not long enough ago for the genetics to be different, but pre-industrial skulls had a full complement of teeth, including all their wisdom teeth, and their jaws were wider and their faces were broader. And that meant that their nasal passages were more allowing for airflow. So when we start to think about the fact that one of the moving parts of sleep apnea is not just how floppy is your airway, but what does your face look like? Is it narrow? Do you have a chin that is backward and small? Those elements are associated with sleep apnea. Absolutely. And the reason for it is postulated to be basically industrialized civilization, that we're chewing differently and we're eating differently from the word go. And we're eating processed foods that are much less difficult to chew. And many of us were raised with bottles, which is very different sculpturally on the midface than it is to have, breastfeeding and all of that sort of tongue working that roof of the mouth. That shapes the hard palate very differently than it does if you're sort of dribbling stuff in from gravity in a bottle.
What really blows my mind is the fact that behavior exchange has driven this physical alteration, the ramifications of which have been seen in people all over the world over the last 100 years. It's extraordinary.
Yeah. It's something that it's very hard to look at, because the repercussions of that line of thought are potentially devastating for folks who are practicing standard retractive orthodontia. And so I think it's a very hard thing to sort of look at, and from what I've seen on my journey, many people just, they can't do it. They can't reflect on this idea because it reflects adversely on sort of professional choices,
Well, you're very clearly a proponent of nose breathing as opposed to mouth breathing. I remember a couple of years ago, I went through a phase of taping my mouth closed overnight. A lot of people have done this. What is your opinion on it?
So this is another place you're going to get some division of thought. Those who are opposed to mouth taping probably have never done it, I would say. But the concern is, well, what if you vomit or something like that? What if you aspirate? And if someone feels that they're at risk to not being able to get the tape off because they've got mobility impairment, then those are things that I would sort of think about more carefully. But as for the physiology of it, nose breathing is just different from mouth breathing. It is just functionally different. It places more nitric oxide into the air that we breathe. So nitric oxide is sort of produced by the paranasal sinuses, and that is a natural antimicrobial. So it's actually nasal breathing is our first line of defense against getting sick. And not only that, when there's more nitric oxide in the air you breathe, nitric oxide sort of made a name for itself when Viagra hit the market. It's a vasodilator in certain places. And so what this allows one to do is nasal breathing just allows better alveolar extraction of the oxygen that we're breathing down at the air sac level of our lungs. So it's just a better way to do it. If you mouth breathe during development, it changes the shape of your face. So it means that your face will develop much more narrow side to side, and it means that your jaw is going to develop in a retracted and smaller fashion. So we've all seen the pictures of the so-called village idiot. It's always somebody standing there kind of with his mouth drooped open, trying to breathe through his mouth. So do I believe in mouth taping? Absolutely, I do, because it's something that you can do to functionally test something. And you can see for yourself, can I make this work? Now, many people have trouble and they feel constant nasal congestion, and they say, well, I could never do that. And they start to get squirmy, and they feel like you're trying to suffocate them or something like that. So for those folks who are interested in nose breathing, I would strongly recommend that you get into the work of one of your fellow countrymen, Dr McCarty. He's made it a career talking about nasal breathing, and he's got some great YouTube videos about how to decongest your nose without drugs. So it's good stuff. And for anybody who's interested in this rabbit hole, I'd strongly recommend they check out his work.
On the subject of the nose, can we talk about a subject that I've heard you discuss before, that of nasal disuse syndrome? Can we go into a little bit of detail on this?
Yeah, for sure. So the more you breathe through your mouth instead of your nose, the more the nose tends to become swollen. The nose is actually filled with erectile tissue in just different place, similar to genitals, right? But that means that it's vascular and it can become very engorged. And so nasal disuse syndrome is kind of what happens when you habitually avoid nose breathing. It decides, well, okay, I'm just going to swell up. And the converse to that is, though, that many people think of that as, oh my gosh, I'm just a mouth breather. and I will never get beyond this. And they may start using over-the-counter decongestant sprays to try and alleviate that, which is a terrible idea for a chronic condition, because that stuff is caustic, and it's a real irritant on the nose. The more you use it, the more you're going to need it. You get a rebound engorgement of that same microvasculature in there. So, again, nasal disuse syndrome is the result of not using it. You get symptoms of nasal congestion, and it fools you into believing that you're going to be this way forever. There are ways to learn to become a more talented nasal breather, to be sure.
Now, people who suffer from sleep apnea can also suffer from insomnia. And I know you're a big fan of a treatment for insomnia called CBTI.
Wow. So this is another great and complex subject. CBTI, Cognitive Behavioral Therapy for Insomnia, is what that stands for. And in my tribal literature, the American Academy of Sleep Medicine, Western Medical, there's a lot of good data that CBTI can be useful in many different contexts. Whether your insomnia is in the context of cancer pain, or whether your insomnia is in the context of being a traumatized combat vet. So what is CBTI? CBTI is an understanding that a lot of our experience of insomnia is innately behavioral and how we process the event. Insomnia is a terribly lonely thing to experience. And for the people who really suffer with it, it becomes a source of expected psychological distress that happens every single night. And there's a lot of self-talk that goes along with that experience, such as, oh my God, I have to get to sleep. That meeting tomorrow is so important. And the self-talk becomes, abusive. It becomes, oh my gosh, there's something wrong with me. It must be my depression, and so people will self-label, and usually it's pretty self-abusive talk. And so the whole experience is very, very uncomfortable and very lonely. And so when people come to the doctor, it's usually they're desperate and they just want relief. And they, if they had an experience of relief with Ambien, which is our version of Zolpidem over here in the States, that's a commonly prescribed drug. If they had a good experience with it once, then they're going to believe that all they need to do is talk you into that, and their life would be golden. So teaching CBTI has the added challenge of people don't want it because they'd really rather have the drug because they know it worked once. So this is why, again, the Empowerment Project is about helping people understand the why of CBTI. And that means understanding the nuts and bolts of how sleep actually works, And so, I would usually teach my patients about how does the wiring of sleep-wake actually function? There's something in the business that we call the two-process model of sleep-wake regulation. And it's really easy to understand when you explain it, but process S and process C is what we call it in the business. Process S stands for sleep pressure, okay? That idea is almost like fumes in the attic, okay? If the attic is your brain, the more you're awake and the more you're doing stuff and the more you're kind of active or perhaps under stress, medical illness can be a stressor too, but the more you're doing that, the longer you're doing that, the more fumes will build up in your attic, okay? Those fumes make us sleepy. Falling asleep, being in a brainwave that is looking like sleep on an EEG, basically changes the way your brain handles fluid. Isn't that interesting? So as soon as you fall asleep, it's like opening the windows and letting a cross breeze fan out that attic and ventilate it out. In your brain, it's actually that the cells of the central nervous system change their conformation so that there is more fluid exterior to the cell. There's more extracellular fluid, which means that a convective current can be established from the CSF, the cerebrospinal fluid, which the brain is sort of swimming in, through the central nervous system itself and out through the venous drainage. So that's the windows of the attic opening. Isn't that awesome? So that's called the glymphatic system, if anybody wants to read about it. But if you think about that, though, it's not all about the fumes, right? Because, if you're kind of doing the mental experiment, I wake up in the morning feeling okay, so my attic is well ventilated. But then, by midday, shouldn't I be like half as sleepy as I'm going to be at the end of the day? Like, why is it that I can feel fine and then get sleepy right after noon and then feel great again? What's going on? That is not just fumes in the attic. And the answer to that is process C. It's a two-process model. So the C stands for circadian. Okay. And what that means, circadian actually means around a day. And our brains are set up to survive in this wonderful place called Earth with its 24-hour cycle. And so that means that our brains know about the whole addict problem. And they have parts of the brain that are called collectively the ascending reticular activating system. These are all neurons in the deep brain. Their sole responsibility is to make you awake. So like if you did a real evil experiment and you burned up all of those neurons with an electrical probe, you would now have a person who is unable to be awake. That person's brainwaves would look like slow wave sleep and they'd be in a coma forever. Okay, so the ability to be awake is structural. And I think that's cool. But even more cool is that the volume knob of how much awakeness they're producing, that volume knob is always in motion. And it dials its way steadily up over the course of the day. Attic fumes, remember? So it's helping us stay ahead of the attic fumes. At the end of the day, like the 2 hours right before your natural fall asleep time, what we call in the business the circadian sleep phase, there's a rough 8-hour time frame on everyone's circadian clock that's permissive for a prolonged nocturnal sleep interval, right? The 2 hours right before that circadian sleep phase, your ascending reticular activating system, your ARAS, is on full steam ahead, full steam. And in the business, what we see, when the circadian researchers named this part of the circadian cycle, they called it the forbidden zone. Isn't that cool? It's like a sci-fi movie from the 50s, right? But the forbidden zone. And the reason they called it that is when they were looking at their double plotted sleep-wake cycles, when you can see sort of like these patterns across time, there was this time frame in everyone's circadian cycle where sleep just didn't seem to happen there. You know, if people were allowed to sort of do whatever they want and sleep whenever they wanted to, there's a time frame in their circadian cycle where sleep just avoided it. And they called it the forbidden zone for that reason. Well, what that means is that the forbidden zone is a time frame of elevated ascending reticular activating system activity, right? I think of it as if you want to go get a beer and there's a big frat boy sitting on the beer keg, the forbidden zone is the frat boy. Okay, the beer is the sleep. Okay, you want to get some beer, you got to go through me. Okay, so people who come to the doctor saying, I can't sleep at night, one of the most common things we see is something called delayed circadian sleep phase. It's like a social jet lag, okay? Because right there in the middle of the forbidden zone, there is an event, a circadian event that's measurable. It's called the dim light melatonin onset, or the DILMO. That's what people in the business call it. I call him in the book Captain Dilmo, like he's an airplane captain, because what Captain Dilmo does is when he comes to work, he tells you to put your tray tables up and he gets the plane ready to land. Okay. And, get the drink service out of the aisles. We're going to get the landing gear deployed correctly, all of this stuff. So the thing about Captain Dilmo is he is exceptionally shy and he doesn't like light, especially blue wavelength light. So you can actually suppress him. Literally, Dilmo is measured by having people spit cereal into a cup because you can detect melatonin in saliva. And if under dim light conditions, there will be a time frame when all of a sudden the concentration just goes way up. Okay, and that's usually in the 1 to 2 hours before your natural fall asleep onset, right? So what we're doing as a civilized world is we are making Captain Dilmo late for his shift every single day. Okay, so he is showing up when you go into your bedroom and turn your lights out. And what that means is that his shift is a preordained duration. You can think of it that way. So the dim light melatonin onset is delayed because of looking at screens and being around bright lights and things like that. And then its offset is delayed as well. And the way that's experienced by the patient is difficulty getting going in the morning, okay, because you've still got melatonin clouding your brain. So what people learn from this is, I have insomnia and I need a frappuccino in the morning. Okay. So this is the adaptive habits. And so when someone experiences insomnia because they're arguing with the frat boy on the beer keg, the solution for that is not to drug the frat boy. The solution for that is to change the timing of their circadian rhythm. And this gets us back to the question about CBTI. Okay. When I teach people about the 2-process model, then we can go back and we can explore, and they can be encouraged to inventory what they're doing that may be hurting our fellow teammate, Captain Dilmo, and they'll be able to understand and explore what effect light has in the morning. So if you're going late and you're kind of driving to work with your sunglasses on, you're missing the opportunity for that light to push backwards on your circadian rhythm. Okay. Once people understand the mechanistics of it, and you give them the agency to understand and sort of make decisions, then the CBTI instructions they don't come across like eat your vegetables anymore. They come across like, here's what the cave looks like. What do you want to do? And here's what I understand, and here's what we can try. So some of the things that we tell people to do in CBTI, one of them is kind of counterintuitive. It's called sleep restriction therapy. Okay. So what I would tell people is, if I got a strong signal that they had this social jet lag, circadian misalignment, delayed circadian sleep phase, if I get a signal that that's happening to them, I'll say, look, here's what we're going to do. We're going to set a rise time that you're going to keep for every day of the week. Okay. And that's got to work for work days and weekdays. We want to make sure your process C gets just nailed down, and we want it to be in the right place. So we're going to decide when you're going to get up every day of the week, and then we're going to count backwards from that 6 hours. That's your new bedtime. Prior to that bedtime, you're going to give yourself 30 minutes of proactive wind down time. Proactive wind down time. That's where we're deliberately courting Captain Dilmo to come to work. Low lights, sort of no social stress. It's very relaxing music, chamomile tea. But we're going to give you only 6 hours to ventilate your attic. Okay, that's not enough. We're doing that on purpose, because remember, those fumes, those are internal sleeping potion. Okay, so what we're going to do is we're going to just basically bypass the guy on the keg. We don't have to talk to him. We're going to wait until he goes away, put you in bed. Then we're going to get you up and say it's midnight. We're going to get you up at 6 a.m, and you're going to be sleep deprived. That's cool. That's awesome. Because the next day you're going to have 20% more fumes in your brain, and that's cool. Now, as you start being able to fall asleep easily at that delayed bedtime, we can now start to inch it back 15, 30 minutes a day until we get you that 8 hour, that sweet spot. Okay. We take the stress out of the experience of being awake until too late. We help people relearn how to talk about it and give themselves the self-talk of, oh, if I'm not sleeping well tonight, that'll be more fumes for tomorrow. I'll sleep better tomorrow. So you give them agency to get them out of that at the same time as telling them to do the sleep restriction therapy. This is why I think the empowerment part is so important. If you just tell them to do sleep restriction therapy, many times people will look at you like you got two heads, and they think those academics don't know what they're doing. I can't sleep, and he tells me to be in bed less. What a moron. Another time, I had a patient come to me and said that she felt so insulted because her prior sleep doctor had told her that she had poor sleep hygiene. She thought that she was being told that she was dirty, and she didn't want to go back. Language, man,
Well, I have to give you credit, Dr. McCarty, because I think your approach to your patients and to your book is that you try to make things as fun as possible and as easy to understand. And talking of the circadian rhythm there, in the book you have a drawing of the circadian rhythm, and it really is easy to understand. It makes it accessible, I think, to people, certainly trying to comprehend this complex condition.
That's exactly why I did it that way. The circadian rhythm wheel is an awesome tool. I really love it. I used a less beautiful version of that in clinic for a long time, and when I explained that the two process model to people, and literally it's like watching lights come on in people's eyes. Seeing is believing. When you can spin this around and show them where their forbidden zone is and see why it matters, that there's where Captain Dilmo is supposed to be, and this is where you're playing violent video games, with the lights on because you can't sleep. Once people make the connection that what they're doing is a big part of this solution, then everything changes. But for people who are interested in the Rhythmo Wheel, you can get that perfectly free. It's on our website. So www.empowered, EMPOWERED, sleep apnea, APNEA.com. And one of the choices is Rhythmo Wheel. All you have to do is print it out, and you can cut it out and put it together yourself. So.
Well, what I will do, Dr. McCarty, is I'll put your website address and other contact details in the show notes for this episode so that people can reach out to you themselves. And I'm presuming that for people listening to this, if they have concerns, either themselves or for their partner, about their sleep issues or breathing issues or both, I'm presuming your advice would be to head to their local healthcare professional first.
Absolutely. This is something that, many providers have a seat at the table. And so many people are weighing in on the fate of those who've been diagnosed with sleep apnea now. So I would say arm yourself with knowledge. The Empowered Sleep Apnea podcast contains the information that you need. The book is, of course, available if you wanted to buy that and give it to your doctor so you can talk in the same language. I strongly encourage that. But you can get the knowledge perfectly free from our podcast, and I would encourage you to go in as an empowered and educated person too.
Well, I can tell you this much, there's been no shortage of education for myself, and I would say for the listeners and viewers too. Dr. Dave McCarty, thank you so much for joining me on the Happy Habit podcast today.
Thank you so much.